So I'm going to talk about ACL research and where I think we need to go. It's quite clear that we have many very successful recoveries, and I think ACL surgery in 2013 is an outstanding operation, one of the best operations we do in orthopedics. And over the last year or two, there have been some kind of miraculous recoveries, including Adrian Peterson and a couple players who were done here at HSS.
It's no secret that as our population ages, all arthroplasties are increasing, and the incidence of total shoulder replacements in the United States is no different. It's increasing at a rate of about 10% per year. And as you'd expect, as you increase the incidence of replacements, you're also going to increase the incidence of revision procedures. And the reason for these revision procedures have been looked at ever since Neer first espoused the benefits of a shoulder replacement, and they haven't changed a whole lot throughout that time. Still, the main cause for revision surgery, the main complications that we have is we have component loosening, and we also have instability as well.
I'm going to talk specifically about femoroacetabular impingement and the morphological variants that are associated with joint deterioration. And in the past, we've really limited it to, or simplified it into pincer and cam impingement. And these are really simplistic mechanisms that explain a much more complex three-dimensional problem. Cam and pincer is pretty well understood now. Rim impingement occurs when there's overcoverage on the acetabulum. Femoral-sided impingement is loss of offset of the femoral head. And these are things that we see in total hip replacements just that are occurring in the native hip.
So in the spirit of this, I'm going to start right out into what I think we need to study. I'd like to focus today on tendinopathy. I think we need to study the causes of tendinopathy. In particular, focus on the interaction between biologic and biomechanical factors, which I think are both to be considered and probably lead to these changes in tendons that are so common in our practices. Now, the conventional dogma teaches us that tendinopathy is due to tendon overload, leading to microscopic collagen fiber failure, a so-called failed healing response. This dogma also teaches us that inflammation is not part of the pathologic process, as inflammatory cells are typically not seen in biopsies of tendinosis.
So we started about 15 years ago asking the question, can we even see cartilage on MR, and then trying to prove could we show cartilage as well as could be done arthroscopically, and we're successful in doing so, recognizing that the signal properties we see at any point in time are a function of the extracellular matrix properties as well as the amount of free water. Using high contrast pulse sequence, we can actually generate 3D models nicely of articular cartilage. But we're also cognizant of the fact that there is a normal grayscale stratification that we can see, and that reflects the collagen in the extracellular matrix of the cartilage with lower signal intensity approaching the bone cartilage interface.
You know, you show all of these tremendous variations that you're starting to learn, and it almost looks like it's not one thing. You're really talking about this large dysplasia that takes place, each influencing the other. Are you missing the boat by treating them after the fact when it's already happened? And do you ever see a point where you could do your analysis in a growing child or an adolescent and in some way modify activities or motions, almost like an orthodontist would treat teeth?
So I think one of the initiatives that we've talked a lot about in sort of the hip preservation community is educating the pediatric population and kids about cross-training and overtraining. I mean, we have a pitch count, for instance, in Little League to prevent Little Leaguer's elbow and medial epicondylitis. There maybe should be a limited amount of time people should be subjecting their hips to load during development, and we may be able to prevent some of these deformities from occurring. And I think the biggest problem now is how much emphasis is put on sports. In a lot of communities, you have to declare your sport by the age of 7, and you do it 13 months out of the year, and you're practicing 3 hours a day, or else you're not going to be able to be competitive. I don't think this is healthy for a growing hip.